Our next speaker is Dr. Tamara Coyne Beasley. She's an adolescent pediatric subspecialist who has expertise in equity, diversity, and inclusion and community engagement. She holds the Darrell Dawkins Endowed Chair in Adolescent Medicine, is a professor of pediatric and internal medicine, Division Director of Adolescent Medicine, and Vice Chair of Pediatrics for Community Engagement at the University of Alabama at Birmingham. She's a past president of the Society for Adolescent Health and Medicine and co-chair of the prestigious American Pediatric Society's Committee on Diversity, Inclusion, and Equity. She's co-lead of the equity domain for the Pediatric Pandemic Network, and her presentation is entitled Pediatric Pandemic Network Preparedness and Responsiveness with Community Engagement and a Health Equity Lens.
Thank you so much. I'm just going to pull up the right presentation here. All right. I'd like to acknowledge one of my co-presenters, who actually is Arian Nassel, who we're going to try something very interactive and hope that it works. There's always a risk when you try to engage technology in a way that's interactive, but we're going to attempt to do that to really show you some of the power of the work that we've actually been able to do. So good morning. And again, thank you so much for being here. And thank you for all the presentations that preceded me would actually help to lead into this work. I want to first actually mention some disclosures here on this particular slide. I want to talk to you a little bit about our objectives and as you see kind of here on this slide as well. We have really three objectives. The first for this presentation are to discuss our mission and our vision. We also want to describe the PPN, its community engagement and health equity domain, not only our activities, but also our composition. And we also hope through this presentation to help you to understand our future directions and need to integrate health equity and community engagement across all domains. And we also hope to get some information from you about how we can actually even improve this work as well. I want to share here our mission and vision, which you can see are very much aligned with the mission and vision of our PPN explained to us by Dr. Simpson. There are a few things that I want to highlight that we have specifically thought about as we think about our domain, and that is to think about how we can advance equity and community engagements in pandemics and disaster management, specifically with the idea that we want to meet the unique needs of historically underrepresented children, adolescents, and those families. We want to especially reach those whose lived experiences may not have had full voice. It is our vision that all adolescents, children, and families are engaged in high quality, equitable care and services so that they are resilient during emergencies, disasters, pandemic, and global threats. We first felt that it was really important as we think about equity and how we achieve that in our communities, that we even look at the makeup of our actual committee and our domain. In fact, what about the whole PPN affiliated personnel? So a survey was sent out in February to all of our partners, not just the PPN. And you see we have several partners as articulated by Dr. Simpson. We got about 80 individuals who responded back to that. And you can see when we look at the things that we examined in that survey, that we had a wide array of experiences and background, with the majority of individuals being healthcare providers, which is why it's so important to make sure that we engage our community and our youth voices. Our geography was more primarily urban, but we do have makeup from suburban areas, rural and remote. And our engagement efforts will certainly be to expand our interest in coverage in geography. We have a wide variety also in age, some racial diversity, as well as gender diversity, as well as even gender identity. We were also really interested in understanding what the needs were as perceived by our PPN affiliated personnel as it related to their training needs for health equity and community engagement. And so some of the top requested things included best practices for EDI and data and research. How do we address racism in healthcare, implicit bias, cultural humility, and upstander and bystander programming. So this is one of the opportunities that we have, and we are working with our engagement and our education domain to actually help make sure some of these educational needs are addressed, if not all of them, hopefully. I wanted to acknowledge also our collaborators. One of the things that was really clear to us as we began this process was that our domain would not be able to cover all the local needs or have all the local connections to actually address the needs that were necessary at each hub site. So we actually asked each hub site to identify their experts in community engagement as well as health equity. And you can see we have a variety of amazing collaborators all across the country who are able to kind of help in this work, not only in providing local context and local needs, as well as local and regional solutions, but also allowing us to be able to cover the entire network and very much of the country. When we think about health equity, it's important to think about the framework from which we will use. And we took this framework essentially from work that's done at the National Institutes of Health that help us to look at not only the level of influence, but also the domains of influence, particularly noting that it should occur across the lifespan from all throughout childhood into adolescence and young adulthood. The levels of influence you can see look very similar to what we would see and find in the socioecologic framework. They include things that happen at the individual level, the interpersonal level, the community level, as well as the societal level. And for us to be truly successful in all the things that we hope to achieve through this network, we need to look at all levels of influence, including the policies and practices that we have. And what are those domains of influence? These domains with the levels of influence impact the health outcomes you see at the bottom. These include biological, behavioral, physical and built environment, social and cultural environmental influences, as well as influences in the healthcare system. When we look at our health equity framework here, it's just a further elucidation with much more specifics about what some of the things are in this domain. But we also want to make sure we understand specifically that it includes not only living conditions and other social determinants of health, it includes looking at risk behaviors, looking at disease and injury patterns, as well as downstream and upstream causes. And I want to also draw your attention to what you see on your slide. For you, it would be on your lower left-hand corner. And that is to really address and break the cycle and improve health equity. It requires that we dismantle the root causes of inequities. I show you this slide just to make sure, and I think our first presenter, Dr. Dixon, talked about the importance of things that need to be included that may be outside of our healthcare system, meaning making sure that we also address high quality education and employment, safe and supportive environments, and that along with accessible, affordable, and culturally relevant healthcare will help us to achieve our goals. What is the framework we want to use and methodology for this? We actually want to use and are using a community engaged framework, one that you can actually see here. Through community engagement, we hope to achieve health equity through transformed systems of health, including strengthening partnerships and alliances, expanding the knowledge that we gain not only from them, but from our research and from our listening to our partners. We also want to have improved health and healthcare programs and policies and work towards improving the ability of communities to thrive by garnering and actually amplifying their very own assets and thoughts about solutions. This can only be done by adhering to the principles that you see, the core principles in the green circle in the center of this diagram, which include trust, one of the most important things that you can have with your communities, bidirectional, inclusive, culturally centered processes and products, equitable financing, multi-knowledge shared governance, and an understanding that community engagement is an ongoing process that is co-created with community members, including youth, as co-equals. Well, there's not a whole lot of time, but I want to just provide to you some of our select activities that we have done so far within this domain. Today, I will briefly talk with you about our Family Advisor Network collaboration, the telesimulation program, our needs assessments, geo-mapping, PPN scholars, and youth engagement plans. Sorry, I won't be able to talk to you about everything and in great depth. The first thing I want to talk with you about was actually something that occurred first with PPN1, and this was a development with EMSC, the Family Advisor Network. This was founded actually in 1999, and you can see the mission and vision here. Its real vision is to be indispensable and equal partners to have this network to improve the continuum of pediatric care. Many of the families have served as family representatives to each of the 58 states and territorial EMSC state advisory committees. It's important to know, kind of commensurate with what I've talked about as we think about who we want to engage, that many of these families have direct experience with the continuum of emergency care based on having a child with special healthcare needs. Some of them have also had adverse experiences with a continuum of care, inspiring desires to improve systems and having also a desire to want to give back. There's another project I want to briefly mention that actually is a telesimulation project. And what's so wonderful about this is that it came directly from the population that is being served, which is the American Indian, Alaskan Native population. Many of us already know that these populations experience lower life expectancies and higher disease burdens. And in fact, many of them have limited access to pediatric specialty care and are located in rural or very remote areas. Leaders in the Indian Health Service, as well as in tribal emergency departments, identified pediatric simulation as a need. And that need was met by two physicians listed here on this slide, and they have successfully launched 8 sites with train the trainer modules with the goal of sustainability over time. The goal of this is also to add 3 more sites in this current year, and they're going to be partnering with the University of Utah and the Primary Children's Hospital as the academic medical center. What was wonderful about this collaboration was that it was actually sought to be specific with academic medical centers from the partners. They will also review and provide routine didactic lectures and case review as requested. When we came together as 10 sites, we thought about the best way to strategize how we would function and go forward together as 10 sites would be to actually see what are our needs that are recognized across our own individual sites and what were our commonalities. So we actually tasked each of our hub sites to actually look at their mandated Children's Hospital child health assessments. And what you can see here as we all individually and then collectively described what we found in our child health assessments is that there were a number of things that stood out and a number of commonalities. Probably no real big surprise to you, things that came out, and most of our child health assessments were done between the time of 2019 and 2020. A lot of them weren't done during the pandemic for obvious reasons. The things that stood out to us that were common to all sites were that mental and behavioral health, as well as social determinants of health, were cited by all sites as things that were important for community. Other things that were important, in fact, the next highest thing reported by 6 sites was access to care, followed by safety, violence, and injury prevention reported by 5 sites, and the need to address chronic conditions. But we also noted that there were some limitations with our child hospital assessments, including that they often included convenient samples, weren't generally representative of our states. There was limited to no engagement of youth in response to the questions. There was variable engagement of community members, and many of our community assessments actually talked to service providers as opposed to community members themselves. They were variable in scope, And the context did not include disaster or pandemic preparedness or responsiveness, which we think would have garnered different responses from our participants of that survey. And though even those social determinants of health were actually mentioned as things that were incredibly important, the ability to define those specific determinants of health was also limited. So we wanted to look at that more specifically, since we knew that this was also something that was incredibly important as we think about trying to elevate everyone and improve everyone's social determinants of health to actually give them a greater opportunity to be resilient when the next pandemic or disaster or emergency comes. So to do that, we thought about how might we do this in a way that also gives us data across sites that would allow us to have comparable data, as well as to look at the priorities across site. And so we used a variety of social determinant health indices. These included the Child Opportunity Index, the Child Vulnerability Index, the Area Deprivation, Low Income Access, as well as residential segregation. And you can see a few more here. And the goal here, again, was to use data that has been generated for all of these sites across all of our 10 sites. And so now, with a little bit of trepidation, I'm going to turn this presentation over to my colleague, not because it's her, of course, but just wanting to make sure that the technology works. And so I'm going to try to turn this over to Ariane Nassel to describe and demonstrate this project a little bit further and the power of geographic mapping. So I'm turning it over. Ariane, if you could share your screen and show the maps that you've developed.
Hello, my name is Ariane Nassel, and what I'd like to show you today is in development. It's the PPN Health Equity Dashboard, which is an interactive web mapping application built using cloud-based geographic information system technology. The tool itself is easily distributed by simply copying and pasting its associated URL into any email message or social media post, and anyone with the link can access the tool, and it can also be easily embedded into a website. So the mapping dashboard is actually designed to visualize and analyze location-based data regarding community-level social determinants of health, including the indices related to vulnerability, resilience, and access to health resources. This enables hub sites to better understand the distribution and makeup of the population within their catchment areas. Overall, harnessing this data from a geographic perspective provides valuable insights into the spatial distribution of health equity in terms of health outcomes, environmental hazards, and healthcare services and resources, enabling informed decision-making and ultimately creating better health outcomes. So this tool is, once it opens, it has a splash screen, as you see here, and it opens up to a national level map. And what I will do is showcase here Alabama. What you are seeing is it can be zoomed into individual hospitals and their associated catchment areas. So here we have UAB, Children's Hospital, and just like Google Maps, you zoom in and out. And when you click on a given location, you come up with a pop-up box that provides information about that hub site or about that county or census tract. So data is available. In this case, we're looking at the Social Vulnerability Index, which is mapped in shaded colors of blue, with the lower values being the less vulnerable populations, and the higher towards 1 are the more vulnerable populations. And this is at the county. And you can see here, if you click on a given county, you will get information about that index and its component pieces, which are household characteristics, socioeconomic status, et cetera. And then you can assess what is going on in that area. But not only are we able to view the county level information, but as you zoom in, we come upon more granular level data that is related at the census tract. The census tract is often used as a common proxy for a neighborhood level. And here I'm going to turn off the county level data, and I turned it on and turn this off. And here we have all of the information available at the census tract for the same area that you saw for the county, which is Jefferson County, Alabama. So the measures of social determinants of health that we are going to be mapping, and again, this is still a work in progress, they're organized as layers that you see here. They're visualized on the map using the shaded colors that are represented from low to high values and as light to dark colors. The legend is over here, and one of the unique features of this is quite interesting, is that, for example, if you're looking at the Southeast region, you can filter using the interactive legend. And when I click on 0.81 to 1, which are the highest vulnerable locations, automatically we see those locations here. You can see a very clear pattern in Alabama of the area known as the Black Belt, which is known for its very fertile black soil. And so it's a rural, vulnerable population that we have in our catchment area here. But you can also interact with your map in that way, and as you move in and out. And so you can see the different options that you have available here. And what you're seeing at this time is actually the highest vulnerability, as well as the RPL theme 1, which is socioeconomic status. So you can see them in conjunction with one another, and that helps you associate and understand and contextualize what the population in your catchment area is. This is available for all of the hub sites and across the nation, and we're still in progress getting some of those on here. But as you can see, there's a great deal of potential for what is included in here, and also how it is going to be built out further. And so this is what we have been working on and providing and available to all of the network. So thank you for your time.
Thank you so much. It worked. I'm so excited. My big thing for today. Wanted to not only thank Ariane for that presentation and for all the work that went into it. Also want to acknowledge Liz Foster, who was really instrumental in doing this, as well as Dr. Gabriella Oates. So thank you to all of you. And I think the important thing to note is that one of the things that actually came out of just talking with our partners from the PPN is that we're going to also extend this work, not just to our 10 hub sites, but also to be able to map out areas of the Indian Health Service, as well as areas where populations that are underserved actually also live that aren't generally included in our map. So there will be specific maps to look at our Alaskan Native population as well as our American Indian population. Okay. Really quickly, because I know we're getting a little late on time, just want to talk very quickly that part of our work is also developing the next group of scholars who can do this work as well, with a focus on pandemics and disasters and emergencies. And so we have 2 scholars that are actually assigned to our domain, and we're really excited to have them. Just to be relatively quick, I want to let you know that one of our scholars is Chris Odolini, who is an EMT. He has noticed and recognized, as many of us did, that there are significant mental health needs of our young people, particularly after COVID, which seems to exacerbate and brought to light a lot of the mental health issues that were already there. His desire is to work to establish a paramedic approach using local EMS to actually help triage pediatric mental health care calls, and actually to work with schools to do that. We also have another scholar who just recently joined us, Dr. Renita Parasha, and we're working with her to help her develop her project. One of the things that was also noted, not only in our community engagement, but in other work that many of us have done with the National Academy, is that we recognize that youth engagement through particularly work with looking at the Gulf was not really a part of strategic planning or even engaged in terms of developing solutions and strategies. So we intend very intentionally to have youth engagement as a component of the work that we do, and you'll hear more about that if you come to the meeting in September. But do know that we intend to have youth from all of our 10 sites represented, a diverse group of young people, those who have had the opportunity to interact with the healthcare system and those who have not. And our goal for doing that is really to just make sure that we can have their education, their innovative ideas and solutions about how we can meet unmet pediatric and adolescents. What are their needs and priorities as defined by them? And what are the social, educational, and mental health programs that they need and desire? And we want them to not only help us to think about that and develop those strategies, but to collaborate with us and help us to think about how we make sure we incorporate an equity perspective. And one of the things that I forgot to mention earlier about the work that was being done with many of the things is making sure that our products also allow us to engage a variety of individuals. So individuals who have languages that are different, that aren't English. And in fact, many of our products are being translated into other languages, but also making sure that we can reach individuals who are visually impaired or audioly impaired. So we look forward to engaging our youth. And in fact, that's one of the things that excites me quite a bit. And this picture also is intentional because I want us to think about youth from all walks of life, youth who have various degrees of ableism, religions, identities. We want to engage as many youth as possible. We also want to form not only youth councils, but as you saw in the diagram that Dr. Simpson provided, we intend to have councils that are part and committees that are part of our leadership structure that advise us not only at the local levels, but also the national levels. These are some of the things that we describe with our Youth Advisory Council. We will use the similar strategy also for how we interact and act with our community engagement members who are also adults. In the interest of time, I won't read through these, all of these bullets, but just know that it's a two-way sharing of resources and information. And as I described in our diagram, our community engagement framework, it's about co-leadership and co-understanding and co-governance. I wanted to just briefly, I know it may be difficult to see, but talk a little bit about a proposal from Children's National that's shown here, looking at specifically youth engagement and how we intend to also roll it out to the other sites. It will include from its inputs both project and PPN leadership. Activities will include a multitude of things, but in particular, training youth leaders and engagement. We also want them to be trained such that when they come out, they are actually able to be leaders that can help us develop the short-term, immediate, and long-term outcomes, but they're also able to take their own, what they've learned from us in our experiences, to actually be leaders in their community in other arenas as well. And so when we look at our most important long-term outcomes, it's actually developing a coalition of youth leaders to help address pediatric needs and priorities on a local and national level. And you can see that at the far right in the purple square. So what are our lessons and next steps? We know that what we'd like to try to do is make sure that we can have as many learning opportunities for the PPN as possible. And that includes working with individuals from our educational domain and developing educational curricula and utilizing what's already there, and that's evidence-based. We're also interested in having all of us and our partners engage in taking an implicit association test to recognize and examine our own biases so that we can do a better job of providing care and services for our populations. We also want to learn from our local communities through our community engagement, and we've talked already about increasing the accessibility of our resources. We will develop these short, medium, and long-term goals with our partners and recognize that HE and DEI and CE, they're all ongoing work. It's not always convenient, and in fact, it's really hard. But we want to determine how we can share leadership and goal setting and even evaluation with our partners. And many times we forget that our partners actually have a role in the evaluation as well. We also, for our domain, want to prioritize the integration of CE and HE, community engagement and health equity, and related principles through all aspects of our PPN so that we actually achieve something that looks like this. So we thank you guys so much for your time and your interaction. We look forward to not only your questions that you may have, but also any comments or anything you'd like to add. We'd be happy to try to implement that into our work. So thank you very much.